Good morning, everyone. Thank you for being here of what is the second Digital Health and Wellbeing Conference. We've got a welcome address from our acting VC, Mary Kellett, which is fantastic. And shortly after, we have a 2-minute pitch from a unit in the university called RAS, and Simona will be coming up here to talk about that. And then we open up the conference. We've got 2 sessions this morning, social media in this lecture theatre and environment 1 over in the library. So I'm just going to play the welcome.
Good morning, everyone, and welcome to the second annual Digital Health and Wellbeing Conference, and particularly delegates joining us from outside the Open University. I'm so sorry not to be able to be with you in person, but you're in for a fascinating few days. The Health and Wellbeing PRA team have organised an exciting programme of presentations and networking events for you, and my thanks go to all the team who helped put this event together. This conference is an opportunity to come together and share ideas in a subject area that's not only incredibly relevant to the way we live today, but is also one of the key themes in the Open University's strategic plan, alongside space exploration and citizenship and governance. The Health and Wellbeing Priority Research Area is a university initiative aimed at bringing OU academics together with external business, academics and stakeholders to share knowledge and expertise. It also seeks to foster and nurture collaborations to enhance and increase the visibility of this important subject. We've made great strides since 2016, and this priority research area now encompasses 6 specialist interest groups: mental health, sexuality and reproduction, health discourse, death and dying, cancer diagnostics and therapy, and digital health and wellbeing. This 3-day event will bring business, academia and stakeholders together across a diverse and fascinating programme of presentations and networking events. So I'm delighted to formally open the second annual Digital Health and Wellbeing Conference. Welcome everyone and enjoy the conference.
If Simona would like to come up.
So thank you for having me here. I represent Russ, which is Research and Academic Strategy, and specifically we are the Research and Enterprise subset of Russ. So what do? We do mapping of the expertise and the research areas within the Open University in order to have an idea of what research we can suggest outside, matching it with the interests of the external organizations. But also we can do bespoke support. So if you come to us and you tell us you are interested in something, we can do horizon scanning, we can do funding support, we can apply for grants together, we can help you with the admin. And most importantly, as also the VC just said, what we do is really to try broker communication and establish new connection and foster collaborations. So having said that, specifically for this area of research, we are well aware of the industrial strategy. One of those pillars is the aging society, and the program is being delivering and has already delivered a lot of money for opportunity specifically into 2 topics. So one is data to early diagnosis, and the other one coming soon will be healthy aging. And around these opportunities, we are going to have a Sandpit event, again, thanks to the PRA, at the end of this month. So we're going to reconvene and try to see how we can scope activities further and build together new collaborations. So come and talk to us. We are just outside, and we are here to help. Thank you very much.
Thank you. We do have moderators throughout the 3-day conference, and those moderators, first and foremost, I want to say thank you for agreeing to do those sessions, and you should have a sheet in your pack regarding your moderating sessions. For those that want to stay and listen to the first session of social media, please stay in here. Otherwise, we'll be heading over to the library. Unfortunately, the room that we need to be in, we need a swipe card, so I've certainly got one. And let's get over there and start the conference. Thank you.
Oh, good morning. My name is Matthijs Lucassen, here from the Open University and moderating this first session. And just wanting to say how we have organised this conference to coincide with good sunny weather. Yesterday was terrible weather here in Milton Keynes, and we have specifically made sure that you have very good weather here whilst in Milton Keynes. And we have three of the first presentations here on social media, and it's my pleasure to introduce the first of these being Julie Samuels, who's an independent researcher, and you'll see in the conference proceedings that Julie has a book as well, so you can read more in terms of the abstract, but also in terms of the book that Julie has written.
Thank you. Good morning. I'm Julie Samuels. I'm an adoptive parent, and the little boy that you can see at the conference is my son. He has autism, so that's why he's quite busy. I completed my MPhil at the University of Sussex in 2016, and I've written a book. Prior to university, I was a lecturer for 10 years in London and in Brighton, and I worked in industry as a web developer for the BBC and ITV. So I've done lots of so computing and technology is my thing. It's since my son that my research moved towards adoption, but I'm not a social worker. I should point that out now. Okay, so technology transforms our lives in every aspect that we do. We wake up and we use our mobile phones for, not just for speaking, but for kind of checking the time, whether we're using it for apps or kind of activities. It's something that's part of our lives, how we mediate our lives. For adopted people, reunification is just a click away. So you don't know when and where you may make contact with their biological kin. And technology for that, for myself personally, I think it's a wonderful opportunity. For other people that aren't so sure, it can be a concern. So obviously we are immersed in technology. So for adopted individuals in particular, for their families, the tensions of what reunification might mean is first revealed due to technology. Lots of discussions take place within pre- and post-adoption support about technology and the concerns and fears about how and where it might occur, and if so, how you prepare your child or indeed yourself for that. And it's this collision of technology with the provision of care that has manifested itself in this kind of unmediated kind of contact, and this boundary that was originally there between kind of, letterbox contact right into the family. In my case, I met the biological mother just the once, and that was it, letterbox contact. But the fact is that she recognises my face because we met. I've relocated twice since the adoption. Not that she would ever know where I am, but I know where she is, because I confess I've looked online, so I know where she is. Because it's just a kind of, every adopted parent says, "Oh yes, I don't look," but actually I have looked because I just like to know where they are and what they're doing. It's that kind of preparation. It's not anxiety. It's just that kind of knowing. For me, that knowing makes me feel safe, makes my child feel safe. But with these kind of boundaries of kind of unmediated contact, the fact is, I could get a knock on the door. I might get a phone call. I could get a message online to say, actually, I've worked out that my son is actually with you, and I recognise your face, and can we talk? And that is a concern, and technology allows that concern to manifest itself. And within social work, technology has lots of roles, whether it's kind of casework, whether it's documenting files, whether it's kind of used to make contact and kind of reach out to prospective adopters. Technology is used all the time, and it's understanding and working out what the balance and the threat is to social work, but not just to social work, but to the carers and the people that they intend or want to facilitate and help and improve their lives. So particularly, which what my interest is in with technology, it facilitates these kind of conversations and dialogue within the adoption community. And there's a huge change going on, because initially, adoptive families, they were in one camp, the biological family were in another, and the adoptees kind of would migrate between the two. Within these online communities, everybody's talking to each other. You're learning from each other. And although there's this fear, for me, it's this wonderful opportunity to learn and to understand how the people within the triad feel about themselves and each other. And for me, it's a wonderful opportunity. Okay, so there's the anxiety about being able to kind of reconnect and not knowing when this might happen. But at the same time, the shared personal experiences of adoption are truly enlightening and they're absolutely wonderful. And actually, these conversations, they allow us to rethink what it means to be adopted in the 21st century, because technology is changing every aspect of our lives. And also for adopted children, the immediacy of contact, that's a huge change as well. So obviously these online resources, they cannot replace the face-to-face contact. There are so many sites online that you can choose to engage in discussions. I mean, how do you choose? The celebrities endorse some, adoptive families have others, social care providers, they also have them that you can use. And everybody experiences adoption differently, and that's what I think is key. Everybody experiences it differently. Everyone that's been touched by adoption, and you may be watching Coronation Street, and there's an adoption storyline on that. And you may feel, and that may generate a feeling inside of you. But everybody experiences it different, and everyone's understanding of adoption is different. And these online resources, where these discussions are taking place, that's where you find out about it. But also remember, adoption is 24/7 and it's lifelong. So all these services that at 5 o'clock you can't get hold of your social worker because they've gone home. For those connected by adoption, like the families, the children that have got behavioural issues, come 5 o'clock, if it's kicking off at home, who do you phone? You have to search online and you seek support within online resources, but it's not the same. And more services are going online, which is wonderful, but at the same time, if it reduces that face-to-face contact that we need, it is detrimental to the experience of adoption. Family. What do we mean by family? Adoption has never been a quick fix for people that can't have children. People think, oh yeah, you can't have a child. Some people actually just want to adopt. It's something they've always wanted to do. And celebrities that endorse adoption, that happily, say, this is my child and I've adopted them. There's a sense of pride that they have. They don't seem concerned about unmediated contact because the circumstances which some of those children have come into care aren't the same as children that might have come into care in the UK through neglect and abuse and everything else. Because for those children, how can you say to them, yes, it's okay for your biological family to come back into contact with you because you removed for a specific reason? That there are reasons why children are placed into care, and the notion of the family and what makes a family is really, really important. I mean, for myself, I see as having my son has a blended family. He has a family that he's with, and he has a family that he doesn't see, but he knows they exist, and they are still his family. And I say to him, you do have another family, although you don't see them, they do exist, and they are your family. And that kind of notion of what it means to be family, they don't have to be with you, you don't have to see them all the time. I think that's really, really important to reiterate. But these narratives of family and what it means to be family, these online triad narratives, they offer insight into these new challenges and understanding. We're rewriting what it means to be a family, we're rewriting what it means to be adoption, and we're challenging and assessing how technology informs and transforms what it means to be a family. So these changes in the construct of family, it's being documented, and it's really, really, I find it really, really fascinating. And I don't see it as a threat anymore. I see it as an opportunity to learn and to better prepare myself and my family for reunification, because it will happen at some point, and I want to be prepared for it. But then it also reveals what I consider to be the temporality of family, and that it's fluid and it changes and it's constantly evolving. And this transitional period that often happens after reunification, where a lot of families may say, actually, I don't know what to do now. They've made contact. What should I do? You have a choice. You can either shut down the contact, or you can actually have a discussion and say, actually, what is it that you want? Is it more photos? Is it more of an update of what's going on? There are channels to use, and you've bypassed those. But now that you've bypassed those, we need to think about what we're going to do about it. And for me, I don't think it's closing down the door, because that says to the child, actually, I'm not willing to accept them as part of your family. And one of the things I think about in terms of family is that family is not bound by blood. We create families all the time online. People talk about, my students who talk about their family. When they meant family, they meant their friends online. That's part of their family. That's part of their community. You know, and technology works really well to sustain elements of kind of connections for siblings that are adopted, because, you know, there are sibling groups online. There's 7 or 8 children that want to be adopted together. And there are very few families that can take on 7 or 8 children. So for those children, you know, through no fault of their own, they are separated. And if they're separated all over the country, all over the world, technology allows them to kind of keep in contact, communicate, and have a understanding of themselves and their identity. And that's where technology is very, very positive. And these kind of new tensions that exist, they're often not about being kind of scared. The fact is that you're disconnected from somebody that you love, and you know that your brother or sister or sibling is having a different life to you. And when you meet up, it's a case of, so you're doing this, I'm doing this. And they don't always understand why they have to be separated. And it's because maybe the families are just too big. But technology allows them to kind of keep together and reconnect. So in terms of opportunities, I think there are wonderful opportunities to be had. I've got over the fear of knowing that the biological family may come in contact and they say, actually, we want to come back into your life. There are boundaries, and they can't just tip up, and I know that, and I'm sure they're aware of that. But if it requires that we need to go beyond letterbox contact, and I have to send some photos, I would happily send photos. If occasionally we had to have a phone conversation every 6 months for a year, just so she can hear my voice, just so she can be reassured, that they can be reassured that everything is fine, then I don't have a problem with that. But please do not knock my door and say, hello, I'm here, because we're not at that stage yet. So there are many challenges. Social media is always seen as the latest threat. I don't think it's a threat anymore. I think if you understand technology and you prepare your child and your family, I don't feel it's a threat. I think it can enhance, because you have to talk about technology. If your child is using technology at school, at home, sometimes it's done in isolation. You need to be able to say to them, okay, well, let's have a conversation. What are you looking at online? Why are you searching? Tell me, because I may have those answers. If you want to do it, let's do it together. Don't do it on your own. But unless, of course, you have this conversation, social media will always be a threat to adoption. It creates these new blended families, and I think the idea of a blended adoptive family where the biological family and the adoptive family are together, whether they're not physically together, is a wonderful notion to take, because that child belongs to 2 families, and you have to accept that they belong to 2 families. If you can't accept that, then you're always going to be in fear. I've accepted that my son belongs to 2 families. One is with, and one that he doesn't see, but he knows they exist. And that's why I think I don't feel threatened in the way that a lot of families I've talked to do. And remember, the completed search is not the end; it's only the beginning of a period of adjustment. So once you reconnect, the adjustment starts. Like I said earlier, a lot of adoptive families that I've talked to, they all say, I did look online, I did see what they were up to, and I said, and what happened? They said, it was fine. I said, yeah, we do, as adoptive families, I said, we say, we've done that, but at the same time, we don't want the biological family to do that to us. There's this kind of the boundary. If we can do it, but they can't do it. They want to know what's going on as much as we want to know what's going on. And if you're more open to the idea of adoption, and you accept there are 2 families, you don't have to be sneaking around having a peep on someone's Facebook to see what they're doing, do you? You can just say, actually, we accept that there is further openness within the family. Yeah. So there are examples online I'll quickly go through about somebody that found their birth mum online, and they were confused. They didn't know how to respond, whether they should reconnect with someone who willingly gave me away. Now, they're not always willingly given away. But for this case, I need to seek out someone who willingly gave me away. It's quite interesting in that there. And the response is to take things slow. Don't go too fast. Pace yourself, because there's an emotion that that's there when you rush in. Take your time, assess what is best. And what's interesting with these online conversations, there's this retrospective voice. There's the voice of the biological kin that you didn't used to hear. They'd write books facilitated by somebody else. And now they talk openly about what it means to adopt. And they talk about their pain, their frustration, their loss, their grief, and the survival. Because within adoption tribes, there are people that everybody loses something, but everybody gains something. And that's what I think we need to think about when we talk about social media. And this voice online, it's not censored. We haven't got social workers or healthcare professionals saying, this is what you have to think, this is what you say. This is their voice, this is our voice. And we use social media in that way to inform and share. And there is this new transparency, a further openness within adoption. And America is very, very keen on this openness. But for, if your child has been forcibly removed due to neglect, then you can't say to the biographer, yes, you can have instant access to the child because there are reasons why the child is removed. But further openness is not about direct contact. It can just be, like I said, about sharing more photos, more conversations, and talking about the biological kin, that they are part of your family. It's like our family, a big family. Like I said, so there are these challenges. Further openness would mean that you don't need to search. A child does not need to search the biological family in isolation because they know who that family is. They know that they exist. And there's increased empathy. I have a lot of empathy for the biological family. I really do. I have a wonderful child that they don't see. So for me, there could be benefits, but there are challenges. It's not applicable to all children. Prospective families are now feeling pressurised to engage in adoption that is more open. They don't want it, but technology has forced us into this situation where we have to consider it. Adoption is not a one-time transaction, it's lifelong. And we have to accept that this is a journey that, as an adoptive family, biological, we go on together. And to remember, family isn't made from blood, it's made from love. And I think for adoptees and people working with healthcare professionals, working with adoptive families, if you think about it in that way, everybody benefits. Everybody's got a lot to gain. Social media is not a threat. It enhances and it can improve our lives. Thank you very much.
Thank you very much to Julie. And the talk about family, definitions of family, online environments and adoption, and some of the challenges and some of the opportunities. We've got time for maybe one or two questions.
Hi, thank you for your talk. I maybe didn't understand you correctly, but you gave sort of two examples. One of the biological parent reaching out, perhaps through email, I wasn't quite sure, sort of through the unauthorized channel.
Yes, that's right, yeah.
And feeling, you didn't seem to be discomforted by that.
Yeah.
But then you also said if they had showed up at the door and
Yeah.
knocked at your door,
Yeah.
then you would be. So there is that sort of tension of what's maybe okay in the digital space and what's not okay in the face-to-face.
Definitely, yeah. I think if somebody makes contact via social media, you say, okay, you've made contact. I have time to think about it, process it, and prepare the family for it. Yet if someone knocked on the door and said, hello, I'm the biological family, they're there in your face. And I think that's due to social media, we have to think about these conversations. We have to prepare. You cannot leave it till the child is 8 to say, oh, by the way, you're adopted, which has happened. You have to prepare. The child needs to know that they were adopted at an early age. They have a biological family, and that they may reach out to you. If they reach out to you, you need to let your family know that this is what's happening. Don't go giving them your address. Don't give them your contact details, which some children have done. And then suddenly somebody's at the door, or there's a phone call say hello. Social media. It allows you still to mediate in some way, so you have to embrace and accept the fact that the family does exist, and technology may be your final buffer in terms of that stops them knocking on the front door. So I think it's, for me, like I said, I wouldn't want it to happen because my son is only 6 and he's not quite, and he understands, but he's not ready for that.
Can I just ask you a question about if you know about kids using Facebook groups or forums for discussing adoptions and the procedures, or even having like some kind of peer communication between people who has followed this process? Because I know there are Facebook groups for parents to go through the adoption process, but I want to know if you're thinking about groups for kids or for
Most of the groups online are parents talking about adoption. There are some, and the parents tend to be the voice of the children. If you have like adoption kind of groups where you meet in person, then the teenagers predominantly they will talk more open. But teenagers and children that are adopted, they talk, but they don't use social media per se to do it. It's more the family voice, that comes through technology. But there are groups set up where for kind of teenagers to talk online, but most of those do have a lot of kind of family input.
Thank you. I don't want to cut short the questions because I know people will have more questions. I'm just conscious of the time, and luckily we do have a break after this session, so you'll be able to seek out Julie and ask her more questions. And if we could just offer a round of applause.
Thank you. Thank you very much.
So our next speaker is Lauren Bussey from Northumberland University, and I'm handing it over to Lauren.
Thank you. Thanks very much. Okay, so hi everyone. Good morning. I'm Lauren. I'm from Northumbria University, and I am currently in my third and final year of my PhD, so I don't have as much experience talking to groups of people as Julie did there. She did a really great job. So yeah, I'm just going to hop on over to kind of show you whereabouts my PhD this particular study lies. So I'm today talking about my PhD study 4, which is actually the quantitative study, the first quantitative study that I conducted, which was born out of the outcomes of my first 2 qualitative studies. And I'm going to get into a little bit more detail about the rationale behind those studies and how it fits in terms of context to the present study. But my PhD on the whole aims to investigate how we are at the moment using online health information and how we are processing and integrating that into our real life health decisions. And it is something that I'm sure that we've all done. I've definitely done it myself. I've had a bit of a scratchy throat or a few symptoms. I'm not quite sure what to do about it. I'll have a quick Google, and we know it's probably not the best or the cleverest thing to do in the world, but we just can't help it. It's there. And we do know now that the internet is being used for these types of decisions more regularly than previous. So a little bit of background then. The internet is a very pervasive health resource, and it is something that a lot of people are using. Accessibility and just the ease of having it at hand at any moment in time means that a lot of people are using it for health information. It's also really encouraged by government and professional bodies now, in particular our Department of Health really encourage participant activation and engagement in their own healthcare. We know this to bring about some good health outcomes, good adherence and compliance to medication, or kind of health protocols that have been put in place with the health professional as well. Because we know that if patients are more engaged and they're interested in learning about how maybe symptoms occur or how they can treat it or dissipate these symptoms, how medication might be working, we know that they're a bit more compliant and more likely to adhere because they've got some kind of understanding as to how that's working for them. We also know from the literature and research that kind of engagement in healthcare can have positive outcomes to the health professional and patient relationship and that integration at the appointment. If patients are searching online, they're becoming more familiar with terminology. They're able to present their information to the doctor more coherently, with more clarity. They're able to ask questions that they've learnt from online, and it really supports that kind of collaborative discussion between the doctor and the patient. So the internet has been hailed a catalyst for patient power, and that was in our Department of Health. They've really pushed this, as I just mentioned. It has a lot of positive outcomes and benefits to the patient as well. So how exactly is the internet supporting health? Well, in my PhD in particular, we've identified kind of 2 main types of websites that people tend to use to help their healthcare, and we've termed these static websites. These are things such as the NHS Choices website and things such as WebMD. And these are very factual websites where the information is presented and we choose what we do with that information. They're very trustworthy and credible. It's very clear who owns that website, who the source is, and it often has information at the very bottom about when it was last updated and when the information is due to be reviewed and updated from then on. So we can kind of make our own appraisal as to how we think if this information was trustworthy, credible, and whether we would consider that in our health information decision making. So the second type of websites that we've kind of looked at and what we've termed patient experiences websites, and you might be familiar with a few of these. Essentially, these are places where patients can upload and collaborate their own knowledge, share that with other people, and we can use that in our own health decisions. We can impart on discussions. And some websites, for example, are these Patient UK websites. So you can see there that there are a few types of discussion forums that you can tap into and upload your own content and read each other's content as well. And actually, this is actually encouraged. You can see that there's a little badge there that says join the community. You can earn badges and increase your reputation by engaging in that conversation with other patients. And other types of places are things like social media. So Facebook has a lot of health groups. One of these is actually one that I'm a group of. I've obviously not captured anyone's names or anything there, but this kind of shows you the type of things that people are discussing. They're discussing treatments, how to cope and how to manage particular conditions with other people with those conditions as well. So two very kind of different types of websites, static information and collaborative information. So a little bit of context for the study findings that I'm about to present. Like I mentioned before, these were born out of the first two qualitative studies that I conducted of my PhD. And the rationale behind these was that the literature in terms of how are people using health information to support their decision making focused very heavily on individuals with long-term health conditions. For example, fibromyalgia, Sjogren's syndrome and type 2 diabetes were very big players in the literature. However, what wasn't considered in as much detail was people using the internet for very short-term, very acute minor ailments and complaints, which, like I've mentioned, I've definitely done. If I've got a headache or a slight symptom, we want to know what's going on. Do I need to go and see a doctor? Do I need a little bit more help with that? Those type of decisions in comparison to kind of condition management haven't really been looked at in as much detail, or if not at all to our knowledge. Secondfold is that health decisions in the literature have been reduced down to kind of treatment decisions that occur in a one-off dyadic encounter with a health professional. However, we know that from, for example, Tim Rapley's work on distributed decision-making, he acknowledges that decisions actually occur over time and across different technologies, involvement of different technologies, conversations with friends, family, different people. Along the kind of trajectory of your health problem or complaint, decisions are made and are changed and adapted as a result of these different encounters with people and technologies. So therefore, these first two studies that I conducted, I interviewed individuals with both chronic and short-term health conditions and investigated how they're using the internet to help them with any health-related condition decision that they have made in regards to that condition. And we didn't reduce it down to just treatment decision. We wanted to know about absolutely any decision because we know that they do exist. So the main findings that there was differential use of online health information for the health decision making. We found that individuals with short-term health complaints were particularly interested in using the static websites, and they were using this as more of a stepping stone to decide, should I be seeking more help for this problem, or do I just park it, leave it, it will probably sort itself out. They were using that as a triage tool. On the other hand, we found that individuals with more longer-term health problems were particularly using the internet for condition management, but also to keep up to date with current trends or kind of emerging ideas and treatments that they acknowledge that have, that they've been improved or that new information's been put out there and they're wanting to find that. And a good example was one participant that I spoke to who had diabetes. She was diagnosed about 30 years ago, and she acknowledged herself that she knew that the information and guidance had changed, but she hadn't got that information from anyone. So she went online, and she found that she was actually meant to be receiving about 10 or 15 support measures, and she was receiving none of those. So that information she was able to take to her GP and say, I'm floundering with my weight loss, I'm trying to reduce my HB1ACs to improve my diabetes. Please, can I see a dietitian? I know that I should be getting off with this, can I have that? And she was successful in being able to kind of integrate health information she'd located online with that health problem with her GP. So therefore, the aim of the current study was to conduct kind of similar, ask similar questions across a larger sample of people. So those two studies were qualitative, and this was a quantitative study to address how individuals with short and long-term health conditions are using the information online to help with health decisions across a larger, more diverse sample. but we also wanted to investigate decision satisfaction, because it's all well and good to ask people, how are you using it for your health decisions? But we need to actually understand, are they satisfied with how the information has helped them with that health decision as well? And if so, through what pathways can we achieve this decision satisfaction? So I used a non-experimental self-report online survey, and it was hosted by Qualtrics. The link was posted over social media. I got in contact with a few groups on Facebook, and their moderators actually posted the link and information on my behalf, so I got some participants that way as well. You can imagine my dismay when I thought, 348 participants, that's absolutely great. When you take out non-responses and the nosy people who just clicked on the survey to have a look if they were going to get anything for taking part, I actually got 196 people, which isn't too bad. Mostly females took part, and we did ask participants how much kind of experience do they have with the internet, and they reported a mean of 16 years. So what did we ask in this survey? Well, we asked a little bit about the health complaint that the participants were completing the study in reference to, whether they were going to be answering in terms of a short or long-term condition, what type of health complaint it was, what they were using the information for. We also asked them about the trust, so how much did they trust the website and information that they were looking at, whether they saw any of these PECS websites, or did they look at any patient experiences. Empowerment. So we measured empowerment in two ways. We looked at cognitive aspects of empowerment, which was kind of the gaining of new knowledge and new information and using that to help make a decision. And we also measured kind of affective empowerment. So how did the information make you feel? And then we asked participants, given what you've read, did you then go and seek further help from a health professional? And bearing, on whatever they said yes or no to that question, they got two separate banks of questions just to delve in a little bit more detail why they felt that they could take the information forward or why they didn't take the information forward. And then we also asked a few questions to determine their decision satisfaction. So on the whole, 77% completed the survey in reference to a short-term health complaint, which was actually really nice, given that we know that in the literature, these short-term complaints aren't really looked at. It's been more focused on the long-term health complaints. And most people were looking at in reference to a treatment decision or whether or not to see a health professional. These, again, are two things that we found in my earlier qualitative studies, so it was kind of nice to see them flagged back up in this larger scale study as well. Participants were mainly motivated by wanting to search for more information to gain more different perspectives on the condition or health complaint that they were searching in reference to, and also to find information from others who had experienced it as well. Most people, well, I say half people, were using the NHS website, but also quite a few did report seeing the PECS information. For example, one of the questions was, the site contained accounts of other people's experiences, to which 76 participants either agreed or strongly disagreed. And a lot of people, as you can see, trusted the website. So 92 and 93% trusted the information and the website. So there's a lot of trust in these websites. So kind of some preliminary analyses, and I'm still actually conducting some analyses as we speak. So these are very early stage. So I've conducted 3 mediation analyses. And first we were interested to see how the role of PECS, so that kind of collaborative information on websites, how was that used to inform health decisions? And what we found was that for those who were looking at the PECS information, they were able to achieve decision satisfaction, but only via this effective empowerment pathway. And this kind of makes sense given that we know that engaging with PECS can help us feel more positive. There's that social support that they are not going through that alone. So it kind of makes sense that reading that type of information would help us feel a bit more confident in making that decision ourselves, knowing that somebody else has also gone through that and has come out the other side. Furthermore, this finding also kind of pertains to previous literature. What we know about PECS information is that stories are processed easier in our brain than kind of more factual and traditional information formats, such as risk information. So we employ certain heuristics to process that information a lot quicker, and it's easier for us to recall at a time where we would need it. So this would kind of suggest that that type of information is being processed slightly different. Okay, so who can achieve decision satisfaction through this pathway? The analyses we've looked at so far, we found that only individuals who had long-term health complaints were able to achieve decision satisfaction through this pathway, which again kind of makes sense given that we know that those with long-term health conditions actually prefer to look at this type of PECS information. It does depend how far down the line they are in that health condition. If they're early on, they're still probably wanting to look at some more factual information, some more risk. If they're a little bit further on in the line, they're becoming a little bit more of an expert in their condition. They're probably looking more for condition management. So they're using the PECS information and obtaining that kind of positive empowerment through that pathway. Again, these are in line with my earlier studies, so that was really nice to see. Again, it suggests that information is processed differently and that individuals can reach decision satisfaction through different pathways using online health information. And the final mediation that we ran was to do with trust. So trust is something that we know is quite prevalent throughout in the literature, how much we trust websites and how that can influence the decisions that we make, how likely it is that we would then take that information forward to discuss with a health professional. So we found that in terms of trust, that was able to kind of bring about decision satisfaction only through positive effective empowerment. So the effective empowerment's positive that kind of side to it was things that people felt more confident to make their decision. They felt more prepared to make their decision. And so trust, and because that information was provided by people who were very similar to themselves, who have experienced the decision, going through how to make that decision, what information to consider, and the outcomes, they're able to note down their experiences throughout all of that. So we think that if people are reading information from familiar others, then they're more likely to trust that information rather than if it was to come from a kind of a statistical website or a very factual website, because they know that someone's gone through that and they kind of feel empathy with that, and they can then feel more kind of satisfied and kind of boosted to make that decision themselves, that knowing that somebody else has, and that they trust that information because it's come from somebody in a similar situation. So just to quickly recap then, main findings was that we found decision satisfaction could be achieved by engaging with PECS information in particular, and that we feel that the results kind of show this differential use of information and how that it's processed slightly different from individuals using short and long-term health conditions, the internet to use to support those conditions. We've also found that trust can lead to decision satisfaction through positive effective empowerment. Again, just that knowing what it's like to physically and mentally experience going through making that decision and the experience of maybe the treatments and outcomes is something that really supports and helps people give trust to that information. So to conclude, the findings are quite novel because we found that PECS information has a particular effect on emotional aspects of empowerment, and this hasn't been something that's been raised before. So this is something that we're going to look into in a little bit more detail. It does support the idea that narratives may be, processed slightly differently than factual and traditional information formats, and these are things that, are considered when making patient decision materials for, GP surgeries and things like that. We know that PECS information is very persuasive. The findings also provide some really good support from our earlier PhD findings, in that individuals with long-term health issues are still relying quite heavily upon this PECS information. And we've also found a lot of evidence in support of Rapley's notion of distributed decision-making, both in the qualitative interviews and in the question where, in this survey, we asked people what type of information, what type of decision were you making. Although the main findings were treatment or whether or not to see a health professional, there was a lot of other decisions that were involved. So that reflects that health decisions shouldn't be really reduced down to that one-off dyadic encounter with a health professional where we choose a treatment decision. Interesting finding about the trust. Although trust was really high on the website, when we actually delved into it a little bit deeper, we asked participants who they thought owned the site, and although the trust levels were quite high, so I think 92-93%, a few of them actually mistook the owners of some websites. So a few of them thought WebMD was actually a pharmaceutical manufacturer, which is quite worrying because if they're placing a lot of trust in these websites, but they're not actually sure who owns the website or who's providing that information, that's a very risky place to input all of your trust if you're making an important health choice. So yeah, that was kind of a very whistle-stop tour of my fourth study findings. I'm currently in the middle of writing everything up. I'm still doing analyses. So any kind of questions or suggestions are welcomed. So thank you very much for listening.
Thank you, Lauren. You said at the start you didn't feel like you were very experienced with talks, and it didn't come across at all. Well, you did an excellent job. And Lauren's asked for questions, and we've got time for one or two.
Hi.
Thanks for sharing it with us. Ooh, woo. Thanks for sharing it with us. I'm curious. I was really glad at the end that you talked about the issue of of ownership, because I think that's really important. That whether or not they know about the ownership of the site.
Yeah.
I'm curious about whether or not you found any differences in sort of the context of the decision making itself. So was there greater trust when it was a more complex decision, or was there less trust? And vice versa, when it was sort of a simple, some sort of very simple decision that didn't have more grave or sort of fulminant outcomes?
Yeah, that's not actually something we've looked at in too much detail at the moment. As I said, these were quite preliminary analyses, things that we have kind of used as a start to investigate further. That is really interesting in terms of what the decision was and how much trust they had on the website, depending on what decision they wanted to make. So I'm not actually too sure, but that would be definitely something that we would be looking into, kind of support that trust finding there. We definitely want to delve into more findings that we found in this study for that. But yeah, sorry, I can't really answer that at the moment, but it's definitely a good point. Thank you.
Thank you. Thank you very much, Lauren. That's a very interesting study. And I know you said you were looking for questions and perhaps suggestions.
Yes.
So one thing I'd like to potentially suggest, a lot of your findings are echoing areas that I'm very interested in terms of the psychology around behavioural change, and some of the things you talked about relate directly to concepts such as relatedness and autonomy, and also competence, so being competent to make those decisions and have some influence in the decisions that you make, and then obviously being part of those, the PECs type websites where you're belonging to a group that you have some sense of connection with, some sense of reference to.
Yes.
And from a psychological behaviour change perspective, that theory of self-determination seems to fit quite nicely with the kind of results that you've kind of now empirically brought up for why people are doing it. So it's just, that's my initial observation, and it just might be something that maybe we can have a chat over a cup of tea about.
Yes, definitely, that would be great. It's definitely not something that I'd considered. As I said, I'm just kind of getting into that write-up phase of my PhD now, so this is my kind of like last event before I buckle down and lock myself away until I've written the whole thing up. So that's definitely great to know in advance of that, and it would be definitely, I'd like to discuss that a little bit further. So thank you very much for your input there.
Oh, one last question.
Hi, thanks for your talk.
Thank you.
You did great.
Thank you.
I'm a clinical psychologist, and I was just wondering, I'm also looking at social identification processes in a totally different context. But I was wondering, for future research, might be useful maybe look at mental health issues or anxiety levels, because social support can really make a big difference there. And I wonder if that, maybe with social anxiety, for example, if talking with other people online has a low threshold, and it might help to determine if people will seek help after that from a GP, which otherwise they might have been a bit hesitant to do. So
it is something that we have looked at in the first two studies, and I've actually just completed the third qualitative study in which I interviewed health professionals on their perspectives of how patients are bringing information into the appointment. But we also gained that from the patient perspectives. They are feeling much more supported and encouraged by these online forums and sites. Kind of people saying, yes, we've been through it, definitely. It's something that your GP or health professional would discuss with you in more detail if you go and see them. So a lot of the information directs people either away from going to the GP because they found the information, they know that they can maybe treat, a physical health complaint themselves, or it directs them to the GP. So they know that they need to get a prescription. They know that they can only obtain that through seeing a GP. In terms of the mental health side, yes, people do encourage, and websites do actually say, if you're worried about this, please see a health professional. But the mental health side is something that we acknowledge that we do need to look into as a side to just the physical aspects. So this is just kind of the beginning, and I'm looking forward to kind of gathering ideas for postdocs and other studies as well. So mental health would definitely be a very, very interesting one, especially, like you said, with the social support of these groups as well.
Maybe as a covariate or something.
Yeah.
Okay.
Thank
Good luck.
you.
Yeah.
Thank you.
Thank you to Lauren. And just to sort of highlight that we will have a break after the session, so there's more time for discussion and questions. So another round of applause.
Thank you.
So our next speaker is Dr. Gemma Ryna from the Open University, and I've set up the PowerPoint.
Okay, hello. I'll stand here so you can hear me with the mics. So yeah, I'm Gemma Ryna. I'm from the Open University. I've worked here for quite some time in one form or another. My background is actually nursing and healthcare practice, but I'm also a teacher, so I've got a bit of a diverse background, not just nursing. Mark Cornock is a colleague of mine. He's an ex-nurse, but he's also a lawyer, so his role is from a legal perspective, and he's working with me on something called the PRISM project, which I'll explain a little bit more about later. So this is looking at something called awareness to action, which is looking at professionalism in social media. Basically what we're going to look at is, I'm just going to give you almost a whistle-stop tour of the research project that led to this in the first place. We're going to then look at professionalism in social media and how we see that and how we might define that. And then probably give some discussion around the current projects that are going on around this and some of the recommendations for research that were found as associated with this. So, brief summary of the research. So basically, we wanted to look at how we socialise ourselves into social networks and try and inform academics as to how we can not only educate people transitioning into a profession, but also understand how we're positioning ourselves in relation to social media. Many of us in professions have been in a world where we didn't have social media. So we've kind of had to adapt to it and learn about how to use it. And sometimes I think we've attached a lot of risks and negativity around it when, and I know some other people presenting have said, you know, there are some real benefits and opportunities and how we can look at those. So basically, it was a critical realist ethnography. We used a bespoke method of analysis that was developed as part of this study. We observed professionally linked Facebook groups. So these were mainly publicly accessible groups. Focus groups with registered nurses and also academics who were registered nurses. So what we were trying to do is get a feel for all of the different influential factors on how we might socialise into a profession. And then we looked at student nurses, pre-registration student nurses, and we used some semi-structured interviews for those. So the outcomes were that we had 3 frameworks. One of them explained how we're socialising ourselves into this world where we have social media and the internet. What we think and do with the behaviours and associated with social media, and then what we should do or can do with regards to some of the risks associated with social media and whether they actually exist at all. So the first framework was looking at how we socialise. The second framework was looking about how we determine what's professional or unacceptable. And then the third framework, which is the one we're going to focus on a bit later on, is we were looking at how we make decisions about what is professional, what's unacceptable, and whether we have any consensus around that. So just very quickly, so this was the first framework, and this theorised that actually we have our original primary socialisation. This is where we learn about the world with our family, going to school, education. You'd then have a secondary socialisation, which is where we're growing up. We might be exposed to a profession, so professional socialisation.
And then this proposed that actually we've got this level, this online socialisation that might happen at different times for different people and in slightly different ways, and that all three of these types were interdependent. So one might affect another depending on how you experience that and how you've come into contact with that. This then looked at how we learn, and what we were finding was there were some really obvious, unacceptable, unprofessional types of behaviour that were generically accepted as unprofessional and unacceptable. And we were looking at maybe these people might have high confidence but weren't necessarily unconsciously competent in the use of social media. So they thought they were, but they actually weren't. And then we had a spectrum of people who were perhaps nervous about social media, so a bit cautious, but still then perhaps did things that might not be seen as sort of socially acceptable. And that's true for the bottom level. And then we had, and this is a minority actually, quite people who were very confident and what we term as unconsciously competent in the use of social media. And so they were very, very low risk of being seen to do anything at all. And sometimes these were actually the people who were very clever about how they managed their privacy settings and what they posted and how they posted, to the extent that they thought about what groups they were part of and what groups they liked, or and how that might look out in an outwardly facing. And what we did recognise is actually it's really quite difficult to be in that green category, even if you are aware. So I'm inviting suggestions. How do we decide, as people or professionals, how do we decide what's acceptable? If you have a social media account, how do you decide what's acceptable? What goes through your head? How do you make those decisions? Do we think about it? So what we were trying to do is think about that process. Oh, hello, go on.
Sorry, I was just going to try and answer your question a little bit. I think, for me personally, I decide what's acceptable based on the audience that might potentially see what I'm posting. Yeah.
So the question is, do people really actively think about it? So there is some active thought, but there are times where we don't necessarily think that. And what we also found is that, there are times where we have a consensus about what might be unacceptable and unprofessional, but actually something might trigger a change in that behaviour. So I then started to think about, if we're thinking about what's unacceptable or acceptable, how do we determine what is professional or unprofessional? And are the two the same, or are they different? So we started asking questions around, is acceptability the same as professionalism? Or is it okay to have that personal, doing something socially acceptable in a personal world, which might not be professional, but actually if you're doing it in a personal capacity, in your own parameters, is that okay? So there was lots of discussion around that, and what we found was there was very little consensus. So the next slide, I just want a show of hands. Who would determine this as unacceptable? So if this was shared on someone's personal Facebook page, would you determine this as unacceptable? Just a show of hands, who would say that was unacceptable? Would anyone say it was unprofessional? Have one hand. It's on their personal Facebook page.
And what are the settings?
The settings would be that any of their friends could see this. So.
What's the profession? Yeah, if they're a lecturer in nursing, do their students see it?
It depends if they're friends with their students. That's another question.
Okay, so if this was public, who would think that that was unacceptable? Would you deem it to be unprofessional? Some show of hands. Or professional? Okay, so what we were finding is, first of all, there were some uncertainties in the room. Some people were very sure where it was professional, where it wasn't professional. Some people were saying it was acceptable. Someone said, actually, what is their job? Because some people are meant to be more accountable or more professional than others. So this highlighted the fact that, one, we struggled to determine what is or isn't right. And what this meant was that across the country, some people were being disciplined for one thing, whereas across the other side of the country, that it was deemed to be acceptable and they weren't being disciplined. Which for me it seems that's quite an issue. But it also suggests that we've got a little bit of a grey area there, that yes, while there's some things that we definitely know are unprofessional and could probably act on, there are other things that don't, that we don't. And if you're then trying to teach and educate new nurses coming through who have probably never known a world without this, there were some issues about, one, the students thought that something was professional when it wasn't. There were some issues with educators not really knowing what was professional or unacceptable, and not really having positioned themselves with social media in a more competent way than some of the students. So what we found was, if you think about, you have your work life, your professional life, you have a social life and with the public, and then you have what would be your personal life. What we found is there are sort of cooperative and competing values that lead to why you might make one decision over another. And in the online environment, sometimes there's far more overlap than you would normally get, and sometimes far more overlap than you might actually consciously be aware of. And we were trying to look at how we could mediate this and how we could manage this. So we came up with what we were thinking about being proactive. So this is part of the one arm of the A2A assessment tool, which is trying to get student nurses, although it can be used by the registered nurses, it could be used by any healthcare professional, to be honest, who is registered and who is accountable. So we're trying to raise awareness of what you think you're doing in the online environment versus what you are actually doing. So one of the big issues was not only could we not determine what was going on and what we couldn't come to a consensus about what was acceptable and unacceptable. What we also found was, along with that made it more complex, is that individuals thought that they had really high privacy settings. They thought they were being very professional. And then when we got them to actually look at their public profile, some of them were horrified to find that everything was public, or that they were sharing things, even the most cautious students who had, I've come into nursing, I'm going to change my privacy settings. What that meant was that when we went onto their public profile, we were seeing things from maybe 10 or 15 years ago because the privacy settings weren't retrospectively applied. And obviously, so we were seeing things that they were completely horrified to see because they were 15 or 16 years old. So what we were trying to do with this arm of the tool is trying to get people to really think about that. What am I doing versus what I think I'm doing? So that was the proactive arm. The reactive arm is the one that Matthias has shared with you. And this is trying to get us to understand, try and get us to think about an evidence-based way of deciding whether we need to take action on a particular incident or something that we might have observed. So we're trying to get some consensus and consistency and use evidence by which to support that. The idea is that these two tools could be used together. So, for example, if you identify that we've had this incident, we've identified that we probably don't need to report it from a professional perspective, but actually this person really needs to think about their online presence. So you could then perhaps use the proactive tool alongside that and say, right, let's really think about what you're doing versus what you think you're doing. But it also then highlights when you might need to escalate a problem or take some quite serious action about a problem. So the idea is that we were moving away from this, over in this area of the country, you would be disciplined, whereas over in this area of the country, you wouldn't. So hopefully, we have a video. Okay, so the handout that Matthias has provided, I hope some people have got it, is basically, it's like an algorithm where if there's an incident, we start thinking in the context of something called the 3 C's. And it tries to facilitate some logical thought and sort of consistent thought as to what we think is perhaps inappropriate or unprofessional versus have we got any evidence for that. So it's trying to mediate the lack of clarity and perhaps lack of consensus that we have, but also try and raise awareness as to what is or isn't something that's acceptable. So basically the A2A assessment tool, we can use the proactive arm in education, professional education programs, but also within by professionals or perhaps even through performance management issues where there has been perhaps a serious issue. The reactive tools, which is the one that we've given you there, So basically, the idea is that academics or professionals can use it, or managers or organisations can use it to try and steer their decisions in an evidence-based way, rather than make decisions based on perhaps subjectivity or their opinions, or their particular values. Not that there's perhaps anything wrong with those, but what that does create is then inconsistency, and it means that we're not always as objective as we might be. So we have a project, it's called PRISM, which is Professional Regulation in Social Media. So this is the project I'm working on with Mark, and some of these are the very early findings of that. But what we are doing, we are evaluating and validating this tool, and trying to refine it so that it makes sense to everybody, and everyone, for the most part, comes up with similar decisions as a result of it. In which case we will then try and use it, certainly with our students, but also with our colleagues in NHS trusts. So we have an NHS partner who's working with us on this project. The proactive tool, at the moment we are trying to digitalise it. It's quite a complex tool when you put it on paper, which is why I've not shared it with you. It looks very, very busy, but basically it's there to determine whether there's a risk associated with your behaviour and your awareness. So we're trying to digitalise that so that it comes out with some kind of scoring system through a web app or something similar, so that it's quite easy to use, but you can also revisit it if you need to. So the idea originally was that we would use it at different stages of nurse education, for example. So some of the other research that we've looked at, that we've struggled to determine is what the public really deem to be professional or unprofessional. Which is significant in that, you know, the public often, we assume that they see a nurse doing something and then that reflects poorly on the profession. But there is some research to suggest that actually they see that reflect poorly on the person rather than the professional. What we're finding is, because we ran a pilot of the PRISM tool with some members of the public, some of them were thinking that we were being quite harsh about some of the things we were seeing as unprofessional, because they saw it as just something that was very socially acceptable and that, you know, nurses should be allowed to do. So we're going to look at that. We're also going to look at methods of dissemination once we've refined the tool a little bit further, and explore some incidents and decisions associated with these. So Mark, from a legal perspective and an ethical perspective, is thinking about how perhaps the Nursing and Midwifery Council have perhaps made decisions, and how we can perhaps apply this to some of those decisions, and make sure that they are ethical and consistent.
Thank you, Gemma. I'm going to go home later today and check my Facebook settings another time. Any questions for Gemma?
That was a very good talk, Gemma. As you probably know, the settings for privacy are changing soon. Yes. And as a Facebook user, you might have got in the last few days, or if you haven't, you will get in the next few days, the chance to change your privacy settings on Facebook. And it's very important that you opt out of facial recognition. Mm-hmm. Because what it will mean is if you've identified yourself as a picture, that's me, I can confirm that's me, every instance of you in every other post will then be identifiable as you. This is what Facebook is doing. The algorithms they're using, their supercomputers they're using, trawling through all the images on the internet and identifying all those associated with you in whatever capacity. And I think it's very important for people, particularly nurses, to make sure that those settings are set to do not allow. Yes. In fact, I would even go as far as to say, get rid of your Facebook account and then maybe in 3 months' time resurrect it in a different form, which is a more professional setting.
They are actually promoting that as a positive thing. I've had my tick list through. Incidentally, I'm not on Facebook as me. I'm on Facebook with an alias. So it's slightly harder to find me, although not impossible to find me.
Thanks for your talk. I liked your emphasis and focus on professional work and professionalism. I'm not sure if this is part of your research project or part of something, you know, larger scoping. Do you find in general that most professional associations are dealing with these kinds of questions, or are they really struggling to figure out how they need to revise their codes of conduct? And can any of this be enshrined in codes of conduct, or is it changing so quickly and therefore we really need to look at new ways of thinking what codes of conduct actually are?
I mean, one of the baseline projects for this was we looked at international guidance for nurses on social media. So we looked at professional bodies and what guidance they had issued, if any. And the types of guidance that were giving and how they were delivering it. One of the big issues for me is that they are struggling with it quite a lot. So a lot of it is reactive. It's not necessarily evidence-based. And it's stating quite obvious things that are already stated in a code of conduct. So where they had a separate social media policy, what they were doing is kind of stating things that actually most of the participants in the research and most of what was observed, people knew. So I think the guidance is probably not really fit for purpose, and it's certainly not based on the evidence. It's more based on subjectivity, which is one of the big things that came out of the findings here.
Right, well, another round of applause for Gemma. And so we've got a little bit of time for everyone to head off to their break. The break, I believe, is just out here. And there'll be time to obviously approach the speakers and to ask them questions. So another round of applause just to thank all three of our speakers.